Welcome, everybody. This is Rush University Medical Center Division of Nephrology Renal Biopsy Conference for August 8, 2021. Today's CME activity code is 483160. I see some new people on our list here, and I'd like to specifically welcome dialysis unit. What are the chances someone would be named dialysis unit? Well, welcome dialysis unit to our conference. As usual, we have nothing to declare, and these are being recorded, and they'll all be available on YouTube within the week. We suggest you go to our YouTube channel and subscribe. The patient has been de-identified as usual. Today we've got a great case with some really interesting, hopefully, discussion about what to do with this patient, and this is maybe one of those, quote, evidence-free zones that we seem to have more and more of lately. This is Dr. Baxey's case. He's going to present the protocol, and we'll go from there. Pravir?
Yep, here, I'm going to share the protocol as well. Let me see here. There we go. On the chat so people can see it. And then let's get started here. So our patient is a 35-year-old Hispanic woman who presents with diffuse joint arthralgias and myalgias. And so we're at that point, she was admitted to the hospital and we were consulted for evaluation of hematuria and proteinuria. So she initially presented to an outside hospital about 2 months ago with kind of new fatigue and joint pain that had been slowly kind of coming about. And at that point, she was found to be profoundly anemic. Her hemoglobin was 5.0. She, further questioning, had weight loss, alopecia, and as I mentioned, joint pains, and also some stiffness. So an autoimmune workup was done, and she had a significantly elevated ANA titer with positive anti-double-stranded DNA, positive Smith, SSA, SSB, and mildly positive anti-scleroderma 70 antibody. She was getting a rheumatology referral and then started on ibuprofen PRN. Her creatinine at that point was 0.6 that we were able to find. Unfortunately, we were not able to find any urinalysis from that encounter. And she was unable to kind of see her outpatient team. And then she presented to our hospital with kind of same symptoms and now a little worse over the last 2 months. Her creatinine on arrival to us was 0.65. Her albumin was 2.9. Her hemoglobin was 6.9. ESR is 126 and CRP 6.4. Her ANA was still positive, and sure enough, her serologies were still positive as listed. We did check an ANCA that was negative. Rheumatoid factor was negative. Her complements, C3 was 43 and C4 was 3.0, both very low. We did a cryoglobulin, and that was detected with a cryocrit of 1.0%. Her UA showed 2+ protein and 2+ blood. She had 15 RBCs, dysmorphic, 8 WBCs, and a UAC, so urine albumin creatinine ratio of 0.8 with a corresponding UPC of 1.3 grams. Her main symptoms, again, were in complaints were the fatigue, joint swelling, joint pain. Now she had a little bit of upper extremity swelling, primarily in the hands. She denied any NSAID use of the past week, although she had been using it before. And otherwise, she really wasn't taking anything over the counter, and so a kidney biopsy was recommended. Her history, otherwise, she had no medical history and hadn't been hospitalized or really had any issues. Her medications that she was started on were all since that 2-month ago encounter, which included iron, ibuprofen, PRN, and then she was on birth control. Allergies, none, no smoke or no drugs. She had a family history of breast cancer, but otherwise no autoimmune or kidney disease. Her vitals, her blood pressure was 132/89, heart rate of 70, respiratory of 12. Her BMI was 32. Overall, on exam, she looked pretty healthy, and she wasn't in any distress. The major things to note of that she did have some cervical and supraclavicular lymphadenopathy. She had no lower extremity edema, but she had some pitting edema of her hands, and she did have quite tender MCPs and PIPs. No rash that we had at our encounter, but she said she did have a malar rash in the past when she initially presented. Labs, sodium 139, potassium 4.0, chloride 108, bicarb 22, BUN 15, creatinine 0.65. Her albumin was 2.9. LFTs were unremarkable. Her lipid panel is listed, cholesterol of 109, LDL 68, and triglyceride 105. She was anemic, but her white blood cell count was 3.6 with otherwise a normal diff. Platelets were 167. Serologies, as I mentioned above. The only thing I should add there is a Hep B, Hep C, and HIV were checked, and those were all negative. Her UA, as I mentioned previously as well, with 2+ blood, 2+ protein, 15 RBCs, urine protein creatinine ratio of 1.3 grams, and urine albumin creatinine ratio of 0.8. She did get a CT, pan CT, and she had enlarged lymph nodes in the axillary, subpectoral, and abdominal pelvic region as well. She also had a right inferior breast irregularity. In terms of the kidneys, there was no hydronephrosis, and the kidney size was normal. A percutaneous renal biopsy was performed.
Great. Any questions for Dr. Baxi?
Yeah, do you have any an MCV or iron studies? I mean, is she still menstruating? I mean, just trying to think of other reasons for her anemia.
Yeah, she's still menstruating. And her iron stores were a little low.
No evidence of schistocytes or anything on smear.
No schistocytes on smear.
Right. That's a good point, though. I mean, she's profoundly anemic. It's amazing to me that she sees a rheumatologist. It's easy to say this later, but she sees a rheumatologist for someone who's, pretty sick, and they don't even get a urinalysis. Just rhetorical, I guess. Dr. Corbett, why don't you walk us through this case?
Lupus.
Good. Next, Doctor. No, go ahead.
No, I mean, it's a 35-year-old who presents, with all the features, arthralgias, myalgias. She's got a history of malar rash. She's anemic. She's got evidence of renal involvement, and she's extremely serologically active. I mean, it's interesting that I think it was an SCL70 or SCL7 was her scleroderma was positive. I'm trying to find it. Yeah, SCL70 was positive. I mean, I don't know if she has one of these overlap syndromes, but I mean, that's always possible. I mean, she just has all the serology is, with the exception of rheumatoid factor and ANCA are highly positive. I mean, the elevated cryocrit, I mean, you can see that in lupus. I mean, Ed and Jimmy Roberts years ago showed that, patients, and others have as well, that patients with autoimmune diseases will have a type 3 cryo, which is a polyclonal cryoglobulinemia against polyclonal against a polyclonal, as opposed to type 1, which is monoclonal, or type 2 cryo, which is a monoclonal against the polyclonal. And so I don't know what it'd be interesting to see what comes out of the cryocrit as far as what they found, but 1% cryo is definitely elevated. The urinalysis has an active sediment with dysmorphic red cells, so clearly it's pointing to an underlying glomerulonephritis with low-grade proteinuria. And what I guess what's always impressive to me is that the serum creatinine is only 0.65 with all of these things going on. I'm assuming that the leukopenia, which she may be right at the cusp of having a low white blood count. I don't know if the break point is 3.5 or whatever, but she's definitely got a lower white count, and the anemia may all be a result of her lupus as well, if it's not iron deficiency from her menses. The CT scans showing the enlarged nodes. I mean, you see that in lupus. I mean, you can see reactive lymph nodes. Now, you always want to rule out other things, like a lymphoma, I guess, or some sort of lymphoproliferative disorder. But at this point, with a normal differential and everything else that's going on, I think lupus still becomes kind of the highest thing on the list. The question now is going to be, obviously, for this conference, as much as anything, what's the renal biopsy going to show? And I mean, lupus more than anything else teaches us that we can play this game all day long, and every time we get the biopsy, or many times we get the biopsy, we're completely blown away by what we thought it was versus what it actually was. And so, I'm looking at this thinking she's got an active sediment, all the serology, that this woman is going to have basically a diffuse proliferative glomerulonephritis, a class 4, if you will. More than 50% of the gloms will be involved. The real issue is going to be, is it going to be immune complex mediated, so that we're going to see a lot of wire loops? Or is this going to be something that looks like a vasculitis, where there'll be mesangial deposits with essentially no sub-endothelial deposits? I don't think we're going to see subepithelial deposits. I mean, there's always a possibility that there are a few, but I don't think there'll be that many given the proteinuria, not that that's predictive. I think it's just going to be a really diffuse proliferative glomerulonephritis And the question will be as to whether it's of a segmental nature with pauci-immune appearances, or whether it's going to be the more global with immune complexes. It's possible that this could just be a segmental lupus with less than 50% glomeruli having segmental scars or segmental active lesions. I guess it's also possible this could be mesangial. It's all out there, any one of those. And that's why the biopsy, in my mind, is still going to be really helpful. Does she need to be treated? Well, even without the biopsy, she's got active lupus and needs to be treated. I'm amazed if she's seen rheumatology, she wasn't put on prednisone right away. She has enough reason, I believe, for that. The question is do you put them on anything more than prednisone and Plaquenil? And maybe I'm sure the rheumatologist would even probably think about Benlysta. But the issue of bringing out the big guns, cyclophosphamide, Rituxan, MMF. I think that's where the biopsy is going to be helpful for us. Could it be some unrelated lesion? The first thing I was thinking about when this came up, when he was saying arthralgias and myalgias, and I'm looking Hispanic, I'm thinking HSP. Could this lady, fool us all and have lupus, but also has an IgA vasculitis? I guess stranger things can happen, but it's possible. But I think at the end of the day, this is lupus, and it's just a question of which lesion we're going to see. And in my mind, it's going to be a diffuse proliferative lesion. Hispanic, unlike African Americans in our experience tend to have more of the segmental pauci-immune. Hispanics can have either one. So I don't know which we're going to find, but I'm sure I'm thinking it will be widespread, greater than 50% of glomeruli. I'll stop there.
And so, since you're putting your nickel down, is it going to be immune complex or not?
Well, that's what. Yeah, I'm going to say yes.
Okay. Now you brought up the point of the lymphadenopathy, that we can see this. I remember a case years ago, very similar case. A young woman came in with a lot of systemic symptoms, a lot of serology, and had lymphadenopathy and had some liver stuff going on. And everybody wanted to do every test as opposed to just saying, this is lupus. So you said you maybe have to rule out malignancy. How do you feel like you need to do anything else here?
No, that's why I said I think
Good.
I wouldn't go down the rabbit hole right now because she has lupus. I think and there's nothing pointing to anything else, at this point. And I think you treat these people, and all of a sudden this stuff all resolves, and so it's a matter of just following it up and paying close attention to it. But no, right now I would, given the way she's presenting, I wouldn't go down that rabbit hole. And that's why I brought up the fact that you can see this in lupus, and just as you alluded to, people go off doing all these other tests and find nothing.
Yeah, well, that was obviously my bias, but I remember that case. It's like sometimes, somebody just has to call it what it is. And, we came in and called it what it was. Anybody else have any thoughts, Dr. Gashty?
No, I think Steve covered it. I don't have a whole lot to add. Usually we think serologically very active. The lupus lesion in the kidney is going to be also a bad one, proliferative class 3 or 4. But if you really look at her urine, she doesn't have a lot of hematuria, her creatinine or proteinuria. Her creatinine is normal. So if the serologies were not a part of this protocol, I would say she has like mesangial lupus. But because there are serologies and lupus is sort of a systemic disease, I'm going to say that she probably has a proliferative lesion, and the complements being so low does support more of a immune complex mediated DPGN, but that proteinuria is just not that much. So there's a little bit of data that supports pretty much every class of lupus she could have. So I guess that's why we do the biopsy.
That's a good point about the proteinuria. I know that we always say that high levels of proteinuria aren't that predictive, although at some level it's a little more predictive of a membranous lesion. But Steve, how do you feel about low-grade proteinuria? You remember all the data from the collaborative study group. What do you see? You remember a lot of patients that were about 1.5 grams?
There were some, not many. In the lupus study, I mean, I forget now without having it in front of me that, I think the average level of proteinuria I wanted to say was 3 to 5 grams or so. I'm sure, there were some that might have been around a gram. I don't know that many of them were less than that, but it would, it would be on the low end of the bell curve for sure.
So there's a lot of nice comments in the chat, but it's kind of getting to what my original point was. People bringing up alternate diagnoses, some of which may or may not be related, but I'm not sure. I'm not excited about looking for an alternate diagnosis, and I'm very happy. I mean, I read the first line, Hispanic woman, and it's IgA nephropathy, but that goes away pretty quickly when you get to the rest of the story. And I think this is like Steve said. I said, what is he said? Lupus with long pause.
Now I know we're being set up.
No, I don't think you're being set up at all. But
No, the more you keep kind of pushing it at lupus, is the more I'm starting to think it's something else now.
So Dr. Rubin, what are your thoughts?
Mean, it's hard to add to the excellent differential of Dr. Corbett, but it depends whether you're a splitter or a lumper. I mean, the adenopathy and the positive SSA and the profound anemia makes me wonder about a superimposed lymphoma in this young lady. So I think that that needs to be considered as well. And lastly, with a low C4 and a low C3, I suspect this is classical complement activation mediated by a circulating immune complex, which is something that was already mentioned as well. That's all I have.
Dr. Suki, do you have any thoughts, anything to add to this case?
I think all the possibilities have been mentioned. I was thinking of the possibility of 2 diseases like IgA nephropathy and lupus, both of which can occur in a Hispanic young woman, but that's the extent of my alternative thoughts. I was wondering about her low hemoglobin and wondering about hemolysis, but I see in the chat that a hemolysis study had been done and was negative. So we have yet to explain her profound anemia.
Yeah, that's what really sticks out to me about this case is that hemoglobin is way out of proportion to everything else.
Did we get a retic count? I mean, now that we're talking about this, I mean, if it was lupus, her retic count should be up. I mean, if they can have.
If it was hemolysis.
Pardon?
If it were hemolysis from lupus, but it could just be her being very sick.
Well, that's
having suppressed bone marrow, but yeah.
I mean, with the cryo, you wonder if she has a cold agglutinin or a warm agglutinin, it could be causing a hemolytic anemia. But I didn't see the thing that was in the chat. Pravir, was the retic count normal in this lady?
Sorry, the retic count was just a little above the normal range. It was like 2.97%.
Yeah, but when you but you have to correct it for her hematocrit,
yeah.
So it's not going to be high at all.
And we had, in the chat, we had hematology come by and a full hemolysis workup was negative, and so there wasn't any concern from the hematology team that this was active hemolysis or anything like that.
And it wasn't just pure and simple iron deficiency anemia. Was the other.
And the ferritin was 23, so it was pretty low.
What was her iron sat?
It was, unfortunately, they had checked that after getting her blood, and so that was actually normal.
Never mind.
So that was the only issue there. But
right.
Overall, hematology attributed this all to a component of iron deficiency.
Interesting.
Were the lymph nodes pursued any more aggressively than just?
Yes, they were. So the lymph nodes were pursued. And we can wait, or we can wait for the biopsy, or
we can wait.
Yeah, well, but yeah, the lymph nodes were, as everyone mentioned, the concern. I agree. The anemia of profoundly of 5 just doesn't. Yeah, we don't see that often with just someone walking in without something major going on. So it was pursued with hematology and biopsy.
Did you I mean, now that we're talking about it, was there ever an LDH level done or anything?
LDH was normal. Haptoglobin was normal. LDH
Okay.
Was never elevated.
If it's lupus, it's just going to be hyperplastic nodes. And obviously we're going to find out later on down the road here what it is. But if it's lupus, it's just going to be hyperplastic.
All right. Well, we now I think we have a poll. I want to see what the audience thinks this is going to show. So please vote, everyone. Don't anybody hit the end poll. None of the co-hosts hit that end poll on the bottom. So
you can guess what the biopsy will show since there's only lupus.
Well, Steve was right. It was lupus. Oh, we gave it away.
Well, I mean, I agree with Dr. Sucre. I think I brought it up as well. You know, it's too bad we didn't have IgA as a possibility plus lupus. I mean,
You know, Premier and I talked about that for about 10 minutes, but I wanted to keep the options reasonable. But
because
that's-
yeah, because that can. I mean, it has happened.
So I'll wait a couple seconds, see if anybody else wants to vote. Vote.
So you can share it. It looks like 100% today. Everyone's voted.
Wow. Okay. Fantastic. You want to share the results?
So people should be able to see the screen. Can you see it?
I see it, but I'm not sure that everybody else sees it.
Yeah, it's
There's,
being shared. Yeah.
Okay. So we've got about 10% is class 2 mesangial lupus, about 30%, about a third say 3 plus or minus a 5. And the majority, about 2/3, what's really left says 60% says class 4 with or without a class 5. And nobody bought just a pure class 5. So, and actually it's interesting because nobody, that the lupus membranous wasn't really brought up in the discussion. And I can see why, but as Steve said, you never know. I mean, you can always get fooled and you never know. So I think it's time to look at the pathology and see what it actually is. Time to spin the wheel.
Got to get some music for this next time.
Oh, great wheel. Who shall read the biopsy?
Yeah, we should have the music they have on Wheel of Fortune.
Wild card.
Wild card. Well, I'm going to pick Nerali since it was right next to. Wheel always picks Faraz. I'm going to give Faraz a break and we'll pick Nerali.
Okay, Nerali, give me a second here. I know you're using Usman's computer.
Can you hear me, Pravir?
Yep.
Okay, great.
Nerali is one of our second-year fellows.
So this is the trichrome stain, looking for the chronicity. We have a couple of gloms. I see actually a lot of gloms. At this low power, it's difficult to say if they are globally scarred or not. But with the normal creatinine and overall looking at this, it looks normal at this power. The tubules look back to back. There's not much interstitial fibrosis, not like minimal bluish material, which is focal here. But otherwise, I would say maybe 10, 20 or less than that interstitial fibrosis or.
Yeah, I agree. It's very minimal, less than 5%. Just one small focus I could see there.
Okay.
Good.
So this is the H&E stain, but the highlighted,
that's a
it's
PAS,
PAS, right? Okay, yeah. It looks more pinkish in the basement membranous. So
yeah. So before you go into each glomerulus, I mean, just generally, do you think this is a diffuse process, or do you see any active lesions here? What do you think's going on?
Grossly looking at it, it looks pretty normal. I don't see like something popping out like the crescents or anything which is diffuse, like either in the tubular interstitial area or in the glom. So
okay, right.
Yeah.
Yeah, there's no segmental necrotizing lesions, crescents, anything really jumping out here to make this a class 4. Good.
Okay, and then we have 4 gloms. In the gloms, the capillary loops look open, maybe some areas of mesangial expansion, but that also seems like just focal. Definitely there's no crescents, endocapillary proliferation. Looking at the capillary loop on the side, I don't see any wired loop like the thick
Yeah,
basement.
you know, at this power, we can't really, I mean, we'll see
Okay.
them at higher power, but
Okay.
yeah, I agree.
Yeah,
The mesangium, that does look more prominent here.
Yeah,
with
just
some hypercellularity, and we'll see them at better detail at higher power.
okay. So just the mesangial expansion at this and on most of the gloms, and the tubules look pretty normal, like they're back to back. The epithelium is good. The interstitium, there's no interstitial fibrosis, proliferation. So I'll move to the next slide.
Okay.
So this is the medium to high power. We see one glom in the center. The capillary lumen is patent. There's no endocapillary proliferation. I don't see wire loop lesions. Mesenchyme is expanded. I would say diffusely. And there's no crescents. There's no breaking of like the Bowman's capsule. So just a mesengial expansion.
Any hypercellularity as well, or just expansion?
I don't see. No, I don't see the.
Well, so like right in the middle, there's, you know,
This?
5 or 6 nuclei in a mesangial area. Yeah, just to the left and up a little bit. Yeah, right there.
Okay.
And up to the left of that a little bit. So it is hypercellular in some areas and expanded.
Okay.
But I agree with you. Yeah, there's no active lesion, as we said, in this glomerulus, no necrosis or crescent or wire loop.
David, I have a question. Right at the vascular pole, there's that sort of lightish pink material. Is that a thrombus? Right.
No, that could be you know, a little bit of hyalinosis in the afferent arteriole. No, it's not. That's good that you pointed that out, but it's not. A thrombus would be, you know, plugging that entire lumen. It didn't. That's not a thrombus.
And okay. This is H&E stain, medium power, one glom in the center. So mesangial expansion here. I don't see any proliferation, mesangial proliferation or endocapillary hypercellularity.
Well, again, around the 6 o'clock area, if you just move the arrow down to the left a little bit, it's hypercellular. There's too many nuclei in that area. Yeah, right there.
Okay.
That's all hypercellularity. But the loops around it are open, so it is mesangial. But there's and go up a little bit more. There's, you know, 5 or 6 nuclei in a row. Yeah.
Okay.
Yeah, so the, you know, generally the mesangium should have 3 nuclei in a mesangial area. So these are hypercellular.
Okay. So I would say segmental hypercellularity in the mesangial area. Okay.
And then the surrounding tubules look fine.
They look fine.
Yeah.
H&E stain, high power, focus on the glom. So is this fibrinoid necrosis, the pinkish material here?
Yes, and above it as well. And can you point out there's some carectic debris? Yeah, right there. Yeah. So, nuclei breaking apart. Yeah. So yeah, right in there. Yeah, that's a good example of a segmental necrotizing lesion. As you said, there's necrosis and carectic debris and some proliferation of cells.
Okay.
Yeah.
So segmental fibrinoid necrosis with the carectic debris.
Yeah, so only 1 out of 20 glomeruli had this lesion. And here's the corresponding silver stain to that glomerulus. So what are you looking for in that area?
This area?
Yeah.
Similar to what we saw, like fibrinoid necrosis.
But on the silver stain, what in particular?
The breaks.
Yes.
So yeah, we would look for the breaks on the stain.
Yeah, so you could see it's not intact. It's ruptured and broken apart in that area of necrosis.
And then the other areas, I don't see like spikes or breaks anywhere else specifically. Maybe here, this area.
Yeah, well, so I thought the uninvolved area looked pretty normal here. So
okay.
Some of the other glomeruli had some pathology of the GBM. So that's why the next slide we'll see
So
a
Dave-
silver stain
David.
of another glomerulus.
David,
Okay.
if you look on this slide, you know, and you go to the far left at around 9 o'clock, there's one loop there. Yes, exactly. Are those spikes there or no?
Yeah,
yeah.
that's what I was thinking. Yeah.
Yes, yeah,
Okay.
yeah,
Okay.
good, good pickup.
I got old man eyes.
Yeah.
Just old man eyes.
Well, there's a lot of other stuff, but when it comes to reading the biopsy, it's the eyes.
Yeah. So I think here we are seeing like more of the mesenchyme expansion. On the stain, we are looking mainly for like the breaks and ruptures, spikes. I don't see a lot of
Your
the,
pointer was right there. You see them?
uh,
There's spikes right there.
oh, right. Okay.
Yeah.
And then go along the left side there, some of those en face gloms, all along the left side. Keep going.
Below here?
Keep going higher.
Okay. Oh, higher. Okay.
Okay, go higher.
Hmm.
You see the en face cuts, how they're like, looks like it's like cheesecloth. Keep going to the loop. Right.
Yeah, go straight to the left. You'll see holes and up.
Higher around the
Up at
capillary
11
wall.
o'clock. Yeah, right
There
there.
you go.
Yeah, I see. Okay.
Yeah.
Okay.
Yeah, so we have
there are
holes.
holes here. Okay.
Holes and spikes. So what does that make you think of?
That there is subepithelial or subendothelial proliferation deposits, immune deposits.
Well, spikes and holes would be subepithelial or membranous deposits, right?
Yes. Immunofluorescence, positive, diffuse glomerular IgG.
Oh, okay.
Granular.
So then where in the glomerulus?
Basement membrane and also mesenchyme.
Okay, so yeah, so the basement membrane is granular staining. So what is this diagnostic of when you have this finely granular capillary wall staining?
There is subendothelial deposits.
No, subendothelial are going to be wire loops. So those are going to be, we would have seen those on the H&E as massive thickening of the capillary wall. These are granular deposits.
So
corresponding with
subepithelial.
corresponding with the spikes and holes we saw on the silver stain. So this is membranous lupus.
Yeah.
But in all fairness, I mean, you really don't know where they are in this. I mean, we always look for the smooth outer lining if it's subendothelial. But I mean, David, in all honesty, you can just say it's in the capillary wall, right?
Right. Yeah.
Okay. I mean, so Nerali's right in that respect. I mean, it's hard to pinpoint exactly where it's at, but you're right. Based on at least what we saw on the silver, you'd assume it might be. But I think, the proof of the pudding is going to be with the electron microscopy.
Yeah.
Having said that, I think, the initial pathology to have this many if they were subendothelial without any, with a single proliferative lesion would be highly unusual. And I think also in the setting of the spikes, you could assume that, but you're absolutely right. Until we see EMs, we're not going to be able to say.
But not everybody that has subendothelial deposits has wire loops. I guess that's my other thing is that you don't have to have massive wire loop deposits all the time. You can.
No, I didn't even mean that. I didn't necessarily mean that. I could be wrong here, but this many if they were subendothelial deposits without a proliferative GN, I just think without any evidence of proliferation or the minimal, I think would be unusual.
My bad. You're right. You're right. You're right.
all I
My only point was you can't nail it down just with fluorescence alone, but you're right.
Absolutely.
So likely subepithelial and not some subendothelial with the H&E and other stains looking good.
Diplomatically put.
Positive for IgA, IgM, just focal here.
Yeah. Yeah. The IgM just barely makes it to full house.
Segmental. Yeah.
The IgA is pretty impressive.
Yeah.
And it looks like it's in a capillary wall distribution too.
Yep.
Again, IgG, positive also in the mesangial area.
No, so we're outside of the glomerulus here. These are the round structures with the lumens are tubules. So these,
so it's
this
tubular interstitial area.
Yeah, so this is interstitium and tubular basement membranes. Again, as seen in lupus, you could see immunoglobulin deposits outside the glomeruli.
Wow.
EM. Oh, wow, lot of deposits. So just to orient ourselves, this is the urinary space, sorry, the blood space, and this is the urinary space. And there are a lot of subepithelial deposits here, diffusely all around. So subepithelial, I don't see any subendothelial deposits here. And intramembranous also here, the deposits.
How about the foot processes?
The foot process, they look pretty, there is diffuse effacement, maybe
Right.
some areas which are okay, but otherwise it's diffusely effaced.
Okay, good.
And the mesenterium, I don't see much mesenterial deposits.
Right. Those are in the mesangial notch there as the GBM goes over the mesangium, but I don't see good deposits embedded in the mesangium yet.
Okay, so mainly subepithelial and intramembranous.
Yep.
Again, capillary, the blood space and the urinary space, diffuse subepithelial and intramembranous deposits here, no subendothelial deposits. The GBM, does it look thick, or it looks okay, maybe at this power?
No, it is thickened.
Okay,
In
yeah,
fact,
it looks.
yeah, we could make out some of the spikes that we saw
Hmm.
on the silver stain where the GBM is reacting between the deposits.
Okay.
Okay, yeah, next slide.
So blood space, urinary space, subepithelial deposits, effacement of the food processes.
Mhm.
So at few areas, maybe it's so normal, but otherwise diffusely effaced.
And then there's one more thing I'd like to point out. If maybe somebody with eagle eyes could see it at around 11 o'clock in the endothelium, what would we be looking for?
Oh, TRI?
Yeah.
Oh, okay. Yeah.
You were on it. No, yeah, maybe that one, but the one to the left is a little more yeah, right there.
Okay.
There it is. Good.
So we saw focal areas of fibrinoid necrosis and karyorectic bodies. So that would go with and it was focal, so class 3, and membranous class 5 with subepithelial deposits and intramembranous.
Excellent. Yep. That was my diagnosis.
Nice job. Before we just talk more about the case, I want to throw out a poll. So this is, what would you choose for induction therapy for this patient? Prednisone monotherapy. Remember, there was 1 out of 20 lesions had a segmental necrosis. Prednisone monotherapy, MMF plus standard dose prednisone, MMF plus lower dose prednisone. Urolupus, which is lower dose prednisone, is about 0.5 milligram per kilogram per day. Or rituximab, which goes directly from Rituxan to MMF. Remember, this is 1 of 20 had a segmental lesion, and the predominant pathologic lesion was that of membranous. So let's see what people say.
Couple more seconds here. All right. Sharing the results.
So we've got 1 person for prednisone monotherapy. About half the people, the majority says prednisone, standard induction therapy, MMF plus regular dose prednisone at 1 milligram per kilogram per day. We had about 1/3 of the people opted for MMF with a lower dose of prednisone. Nobody bought urolupus, and a couple people bought into the rituximab treatment option. So that's a lot to think about. Casey, tell me, let me just put this out there. We've got a membranous lesion, we've got a very sick lady, but we have 1 out of 20 glomeruli would show a lesion. How do you feel about that? And how would you treat this? And how do you put it in your mind with only one lesion, with a segmental lesion like that? I mean, the difference between 3 and 4, of course, is 50%, and this is 5%.
Yeah, well, I think one of the aspects of this case that will push me towards being more aggressive is all the extra renal manifestations that she has. So she has such bad systemic lupus that would, for me, be a tiebreaker to kind of side on the side of being more aggressive with treatment. So 1 segmental necrosis or 2 segmental necroses is a segmental necrosis. So I think left untreated, you will go from 1 to more. So just because we caught 1 doesn't mean I wouldn't be aggressive with it. So I would go full induction. I wouldn't just do steroids. I would do steroids plus. And
So what if there?
Yeah.
So what if it was just membranous with her clinical symptoms?
Then you go with what's best for systemic, and then Rituxan could be an option. Prednisone alone in membranous lupus is not really that effective by itself. So I would probably do, to be honest, I think if that 1 doesn't really change my treatment that much, whatever I would have given for systemic plus membranous should probably cover that 1 necrotizing lesion too.
Remember, the original poll showed the majority of people thought this would be a class 4.
Mm-hmm.
Nobody said class 5. We're 1 sample away from this being a class 5. 1 glom out of 20. You could have missed that so
Yeah,
easily.
I mean, it was the degree of proteinuria and all the blood. So yeah, I mean, that's why you do biopsies, right? I mean, we say that at the end of every biopsy conference that has a lupus case, we say that's why we do biopsies, because sometimes there are enough data points in the presentation that would sway you one way or another. But at the end of the day, tissue is basically speaks the last word. So I would, I mean, you're right. The predominant pathology here is membranous, but there's 1 segmental necrotizing lesion, so you can't ignore it.
Yeah, pathology is the issue, but then also your original argument was that you would ignore, she has enough to treat anyway without the pathology. And I'm not advocating for not biopsying. I think we learned a lot here, and I think there's a lot, probably prognostically, and depending on how she tolerates medication, you might handle things differently.
The pathology, so the systemic disease could potentially be treated with steroids alone. I mean, if this person went to a rheumatologist with those labs and those presentations and didn't have a positive UA, she would be placed on prednisone and repeat labs. Now, the pathology actually adds a prednisone plus. So I think the pathology here does actually change the ultimate treatment.
Yeah, and that's probably true. I'm not a rheumatologist, but they might have even started at 20 or 30 milligrams of prednisone and see how she did. And there's probably not enough to treat that other lesion. And who knows, then, 6 months later, her creatinine's up a little bit and you got 20% of those, because she's inadequately treated. Dr. Corbett, nobody predicted this. Obviously, that's why we do biopsies. I mean, basically, this is a membranous lupus with 1 segmental lesion, and I am not downplaying the segmental lesion, but
So Rich Sloan, we looked at this years and years ago with Mel with the old classification 5A, B, C, and D. 5A was just pure membranous lupus. 5B was lupus with mesangial proliferation, which was where this would have been classified without that 1 lesion. 5C was going to be membranous plus segmental lupus, and then 5D was membranous plus diffuse proliferative lupus. And what we found in the lupus study is which we kind of went along with the lupus study, is that the proliferative lesions would define their course in general, and the 5As and Bs did fine with kind of minimal therapy. The Cs and Ds had a much worse prognosis and required more aggressive treatment. But the fact of the matter is, like I said, I went through the whole thing and said it could be any of these, but obviously my vote was towards the much more aggressive lesion, if you will. But the fact that you found one, I mean, I say this all the time. If this was somebody that had an MPO vasculitis and you saw one lesion, you'd still treat it like a vasculitis. And I think you can't ignore that. I mean, it gets back to the whole selection bias thing. If you don't have an adequate sample, you could have missed that, and probably you may not have treated them as aggressively as they deserve to be treated. I personally think that just without the renal disease alone, she would have gotten 60 milligrams of prednisone, because I thought she had pretty severe, I mean, she has a lot of manifestations. And if that anemia is not just iron deficiency, and the arthralgias and everything else in the serology, I mean, I personally would have thought, at least for a short period of time, they would have started her at 60 and tapered her down, as opposed to starting at a very low dose. But that's just me. I think that I agree with the prednisone, MMF, and I'm sure she'd be put on Plaquenil, because that's been shown to be beneficial. I was sitting here wrestling. I had to go back and look, the Eurolupus trial, looking at low dose versus the NIH protocol, they only had a small number of membranous patients. So I don't know, that if we know that the low dose will work as well with the membranous patients, unless there's another study out there. The MMF, we have the ALMS trial that showed that MMF was as good as the patient in patients with membranous, because Jay Radhakrishna looked at that subset of patients, and they did just as well as the cyclophosphamide patients. So I think we can rest assured there that could be beneficial, at least with the membranous. And there are studies out there which Dan Tan from China showed years ago that MMF is as good as oral cyclophosphamide. So I think I like the MMF prednisone in this young woman, especially with the one lesion, the one segmental lesion. I think you can hopefully treat that, and then the question is, and then taper her off the prednisone and get her on a maintenance dose of MMF. And then the question is, how long do you do that, and ultimately try and get her off? And I guess you have to see how everything evolves. But for sure, the extrarenal lupus by itself, without the renal disease, is severe enough that it warranted. And I agree with Casey. I think prednisone and Plaquenil probably would have been enough for that.
So your argument that if it's an MPA and an ANCA-associated vasculitis, it wouldn't matter what percent you would treat with a standard vasculitis induction protocol. Kind of really, which is what I felt all along, makes this whole notion of 50 greater or less than 50% kind of silly.
Well, I think the greater or lesser just gives you an indicator how widespread, and it is prognostic. I mean, if you look at the eurovasculitis data where they looked at the histology, those that have focal disease, which is less than 50%, versus those that had more widespread crescents and those that had more sclerosis, there is some histologic correlation to outcome. And
I understand, but why don't we just say this is the lesion and this is the percent glomeruli, and not have a distinction of class 3 and 4 based on 50 or less than 50? It just doesn't make any sense to me. This is a 3, but there's a 3 where it's 5% here, and there's a 3 where it's 49%, and they're both 3s. And we look closely at the data, but not everybody has the luxury of being able to do that.
Yeah, I guess again, the only data I can, at least with respect to lupus, I don't know if you're talking about vasculitis now or you're back to lupus. But when Mel Schwartz and Karen Koala looked at this years ago, this was part of the rationale behind those patients with 3 greater than 50% getting in the lupus trial. In those days, the classification wasn't so straightforward that if you had more than 50%, you were considered class 4. And in their paper, Karen and Mel and Ed, they did show that there was a difference. The ones with greater than 50% did worse than the ones with less than 50%.
Well, that's no surprise. That's no surprise. I mean, I'm just saying, making a cutoff 50% is silly if clinically it's not going to matter to us if it's 10%, 49%, or 51%.
Oh, I hear you. I think the only way it matters, the only way, I think we'll treat it the same. I agree with you. I think the only way it matters is prognostically.
Yeah, but again, prognostically, instead of giving us a less than 50 or more than 50, just give me a number, This woman has a very good prognosis with 5% of her lesions, as long as she can tolerate therapy. Her membranous is probably a bigger threat on her long-term renal outcome than anything. And I'd also make the point, since you said if it's one glomerulus, we treat it like a vasculitis. We don't have the evidence for this, but you could look at that and say, why not use Rituxan then?
Well, you could. You can use Rituxan for membranous, I guess. I mean, you could. I know in the rituximab trial, I know Bill's quoted that, well, you both have, there were a lot of membranous patients in that trial. So I guess the answer is you could.
Well, I don't even mean that. I mean, Rituxan for what looks like a vasculitic lesion.
Yeah,
There's no reason to believe it will work, but there's no reason to believe it won't work, because it's really the treatment of choice now for ANCA-associated vasculitis with that lesion. I'm just throwing that out there. It's a possibility. I'm not saying I would do it. It's not really been shown. I don't know if they'll ever have that data.
No, I think that's a good point. I think going back to your other point about the classification, I think we should call up Agnes and Babette and get you on the committee to do the new classification.
I think that would be a battle that I would not win. I think I'll stay. I think I'll stay in this soapbox right here in this forum. I'm not interested in getting in a battle there. I can guarantee I won't win that. Anybody else have any comments? Anybody would do anything differently? Javier, what did you do?
That's a great point. Yeah. So what we did is we put her on prednisone. I think I put this in the chat, but the lymph node biopsy did come up as reactive, and so there's no malignancy there. So it's attributed all to lupus. Sure enough, we put her on 60 milligrams of prednisone, and her symptoms dramatically improved in terms of her extrarenal symptoms. Her white count went from 3.6 up to 8, 9 normalized. Hemoglobin went from 7 to 10 without any other intervention. And at that point, I went with CellCep. I did put her on 1 mg per kilogram of prednisone, and she got started on CellCep. And my plan is to slowly up titrate that to see how much you can tolerate, up to 3 grams for the 6 months. We did put her on PJP prophylaxis. She was not interested in further children, and so fertility was not a decision factor here in terms of Cytoxan MMF. I just thought, again, interesting enough, we got that 1 glom, and I think what if we had 19 glomeruli and we didn't catch that segmental lesion? What have I done? I think she still would have got prednisone.
Not only that, you're talking about now you would have found membranous with 1.3 grams of protein.
Yeah.
And would you treat a lupus membranous with 1.3 grams of protein? I mean, we always, the pathology is much more impressive, but I'm not sure everyone would have been that aggressive. They might have.
I may have done ACE and ARB, which we are ACE or ARB, just to get that proteinuria down. She would probably, like we said, got steroids just for extrarenal manifestations. But how long would that have been? I don't think it'd have been full induction that we see with lupus nephritis. Maybe 60, but then down to 40 and 20 off in a month.
Yeah. And
that's really not enough for a proliferative lesion. And what I had done, I probably would have, if she had pure membranous, which is done prednisone, she would have got for extrarenal, done ACE and ARB, and followed her protein levels. And if it didn't, then I would have chose Rituxan versus maybe doing, or I could have done MMF. So I think that would have been really a different situation. But we were fortunate enough to get 1 glomeruli with a segmental lesion. But I agree. I think if this is left untreated, it could definitely lead to damage down the road. But the question was, would prednisone would have been enough if we didn't catch that? I don't know. I really don't know. So I think she's doing great now. The plan is to continue. Her creatinine stayed normal. We don't have repeat proteinuria yet, but overall systemic lupus symptoms and lab-wise, she's improving.
do you think you will? It may be the rheumatologist that do this, but based on everything else, would you do a faster prednisone taper than typical induction?
I don't think I will. But you could. I mean, everything is going towards lower dose of prednisone and giving her down. I just think she was so serologically active, and I think she's made such a big improvement. I think she can tolerate the higher doses of CellCep. Maybe that will allow me to taper down quicker. But yeah, you could argue that it's 1 lesion. Maybe we don't need to do this full prolonged course and tapering it off.
Well, I think there's
that would be my bias, but
one is a vasculitis study, right? And the other, this is lupus, and you've got plenty of parameters to follow. And trust me, I'm all for getting women or anybody off of prednisone as fast as you can, but you've got a lot of parameters to follow, that's for sure. And so that will help you, I think, with your tapering.
Mm-hmm.
Well, that was really good. That was a fun case. It's like Dr. Gashti said, this is why we do biopsies. And in the end, that 1 glomerulus did make a big difference for us. And so it's fortunate it was an adequate sample. If we had 10 glomeruli, it was a good chance we would have missed that. But this was a great sample, and we had great information from it. So we're going to wrap this up. Thanks, everybody. The activity code again is 483160. Keep your eye open for your emails. If you're not on our email list, send one of us an email. We'll get you on the list. And our announcements in Twitter. This will be on YouTube within the week. Thanks, everybody. Stay safe, and we'll see you soon.